Eugene, when they say, Doc, what's the chance that this is going to work for me? How do you kind of have that conversation? And maybe we could start out with patients that have papillary high-grade tumors and then patients that have CIS and then combination patients. And you've done their most recent TURBT and feel like you've, cleaned them out.
Yeah, so I think as you sort of alluded to, I do sort of give like a stage specific or disease specific sort of estimate based off, the data, at least the way that I interpret it. So someone who has, say, high grade T1, multifocal disease with diffuse CIS, like those patients, I sort of counsel and emphasize that there's a little bit of concern depending on whether or not you're worried about potential clinical understaging, potentially even if you're doing it yourself, et cetera. Those patients I'll counsel like the chance that they would derive clinical benefit from BCG may be as low as 50% sometimes. And, certainly that's an opportunity for clinical trials of BCG plus, additional agent, maybe like an immune checkpoint inhibitor in that case, if they have early invasive changes, et cetera. But for a patient with papillary high-grade TA only disease, those patients' chances of response, I typically quote them as at least 80% or so. And those that don't initially respond may be able to be rechallenged with a second induction course or, again, a clinical trial opportunity. So those patients may still derive clinical benefit from BCG that can be long lasting. I do counsel patients, though, that even if they have an initial response, even with maintenance BCG, there's still a chance that they could recur. Typically, I say somewhere around 20 to 30% chance within the first few years. Again, I sort of try to individualize it a little bit more. Patients with multifocal disease, even if it's high-grade TA, I worry more about those patients with larger tumor burden overall, even if, they're fully resected using enhanced cystoscopy techniques, et cetera, compared to a patient, a small solitary tumor. I think kind of risk stratified my estimates to them.
Yeah, that sounds about spot on or consistent with what I do. If it's kind of at the favorable end, solitary TA, high grade, less than 3 centimeters, kind of in that 80% range. Now you're getting on the other end of the spectrum, T1 high grade. I mean, usually if they have LVI, I'm super worried. But if it's, T1 high grade and not chock full, unresectable, early cystectomy candidate, closer to about 50%.